Good afternoon, everyone, and thank you for joining us for today's webinar. My name is Divya Patel, and I'm an Associate Professor of Epidemiology at the UT Health School of Public Health in Austin. Today's webinar is co-hosted by the Michael and Susan Dell Center for Healthy Living at the UT Health Houston School of Public Health and the African Mothers Health Initiative and Joyful Motherhood. The Michael and Susan Dell Center's vision is healthy children in a healthy world, with a mission to advance health and healthy living for children and families through early and impactful interventions. The African Mothers Health Initiative, or AMHI, started with the effort to save the life of one infant following the death of his mother in 2006. Today, AMHI works to provide family-based care to high-risk infants and postpartum women in Malawi. Thank you to the Michael and Susan Dell Foundation for providing funds to the center to host today's webinar. Additionally, information about the center's work and resources can be found online. Please scan the QR code on your screen to access our health resources. The slides and a recording of today's webinar will be archived on our website, msdcenter.org. If you have any questions during the presentation, please enter them into the questions chat box for the Q&A session at the end of the presentation. With that, I'm excited to introduce our speaker, Joanne Chiwaula. Joanne is the founder and director of African Mothers Health Initiative, a US-based 501c3 and Malawian sister NGO, Joyful Motherhood. Joanne holds a Bachelor of Arts from Brown University in International Development and a Master of Science in Nursing from the University of California, San Francisco, where she also became a certified nurse midwife. Joanne moved to Malawi in 2005 and through her work as a midwife there, witnessed women's experiences following near-miss deliveries, as well as unaddressed factors contributing to infant death. Joanne is driven by a desire to serve women who often find quality care in scarce supply. I'll now hand it over to Joanne with her presentation on addressing two largely unexamined global maternal and infant health issues through family-based care in Malawi.
Thank you, Dr. Patel, for that introduction. I really appreciate it. I also want to thank Marilla and the people behind the scenes at the UT School of Public Health for making this webinar possible. And I'm grateful to all of you who have logged in online and are with us today. I'm so grateful for your interest. I'm excited to share with you about our work and equally interested in your questions and feedback afterwards. So I'm going to give a little context first. I know that we have some Malawians online with us, but I also imagine that there are plenty of people who don't know very much about Malawi. And then we'll get into the issues that we are trying to address with our work, the solutions that we are using, and then of course at the end we'll have time for question and answers. So for those of you who are not familiar with Malawi, it is that little orange country in Southeast Africa, highlighted on the map there. Malawi is about the size of the state of Pennsylvania and has twice the population almost of the state of Pennsylvania. The other interesting thing about Malawi is that more than 80% of the population live in the rural areas and survive on subsistence farming. So if you can imagine visually, Malawi looks very much like this picture here in front of you. There are several large cities. Our NGO here in Malawi is based in Lilongwe, which is a city of over 1 million people. But if you move across the country, the majority of the rural areas are divided up into small farms like this. And the other thing that you would notice is there's a significant amount of deforestation. So the people who are living in rural Malawi, they do not have running water, they don't have electricity in their homes, and they depend on firewood and charcoal for fuel. And so that has resulted in significant levels of deforestation, which is a major environmental problem in the country. In terms of development overall and where Malawi sits on a global scale, there is an index, the Human Development Index, which takes into account education, life expectancy, and GDP, and then ranks the countries. So out of 189 countries that have been ranked, Malawi sits at 169 for now. So definitely in the lower part of that scale. With respect to infant and maternal health, there have been a lot of gains in those areas over the last couple of decades, but there's still a long ways to go. And one thing I really would like to invite you to consider during today's webinar is how the data that we collect kind of limits our ability to perceive issues in health and also circumscribes the interventions that we create. So, for example, considering child health in Malawi, we know that the children who die under the age of 5, most of those deaths occur within the first year of life. And most of the deaths that happen within that first year happen within the first month. We also know that the main causes of child death in Malawi are pneumonia, infection, malnutrition, malaria, and diarrhea. So therefore, our interventions kind of flow from those two buckets of information. We are working at the time frame when infants and children are most likely to die, and also on the causes or the ultimate, the causes of child mortality. So kind of this set of data that we collect in order to ensure that we're moving forward, in order to improve child survival, we look at, whether children are born at term, whether they have breastfeeding and sustained breastfeeding throughout infancy, whether they're sleeping under bed nets, whether they're receiving vaccinations. So these are some of the important markers that we're considering. But I would say that when we look at infant health and child health in this way, we're missing an important piece of the picture. I think the question that we also should ask ourselves is, who are these children that are more likely to die, and what do they have in common with each other? So in terms of maternal health in the picture in Malawi, our main marker that we are aiming at to improve maternal health is to reduce maternal mortality. And for those of you who don't necessarily work in the area of maternal health, just to give you kind of an idea of the scale, we measure the maternal mortality ratio as the deaths per 100,000 live births. So in the US, our number is actually lagging behind many countries in Europe. We have 19 maternal deaths per 100,000 live births. In Malawi, we don't even know the exact number. We know it sits somewhere between 380 and 600. So it is a huge problem, a very worthy one that needs a lot of resources and attention, and that is where our focus has been. So in terms of maternal health, when we think about kind of the data that we're collecting and the way we're moving towards reducing that maternal mortality, we look at, how many women are attending their prenatal care visits, how many women are delivering in hospital facilities and attended by a skilled birth attendant, how many women are being tested for HIV and treated if they are positive during their pregnancy. So in this picture of maternal health, again, we're really limited towards this singular goal, and we're missing the broader dimensions of what healthcare is and some of the healthcare problems for women in Malawi and in other low-income countries. Next slide, please. Next slide, please. Thank you. So I want to illustrate some of the issues that we're addressing. Sorry, we could go back to the picture of the family. Thank you. So some of the issues that we're addressing by sharing stories. So this family came to our office in August of last year. The woman here is the mother to these two men and the grandmother to the baby in her lap. And the mother to this baby died 2 weeks after giving birth. So the story here is that the mother, she attended her prenatal visits. She did exactly as she was told to do. She went to the hospital when she started labor. She had a normal delivery that was attended by a skilled health attendant. She was breastfeeding, her baby was doing well, and she was discharged home. Around the 2-week mark, she started complaining of severe chest pain, and her family organized funds so that she could get to the hospital on the back of a motorcycle taxi. But on the way to the hospital, she had a massive heart attack, collapsed from the motorcycle, and died instantly. After her death, her baby was left without breast milk. Her husband assumed primary responsibility of their two older children. They had a 10-year-old and a 6-year-old. And then her mother became the primary guardian for her baby. So now the issue is how is this family going to feed this child? So her brothers took on the task of raising money to purchase formula. In Malawi, in the rural areas, most people survive on around $2 a day. And not all of that is in physical money. A lot of that is, just the product of their work and is an estimate of how much they will be able to generate within a period of a year. So her brothers, they each have their own families. They have children who have needs. They have to, pay for education. They have to pay for clothing. They have to pay for food for their own households. And now they have to generate enough funds to purchase a tin of formula, which is almost $7 for this baby. So generally what happens in this situation is that families will do everything possible to sustain the life of this fragile newborn, but at some point they can no longer keep up with the needs of the growing baby. So families, we've even seen them sell their own store of food when maize is the staple crop, and sometimes people will sell bags of maize in order to have the funds to purchase formula, but at some point they just can't do anymore. So what happens at that point is they will begin to feed the baby whatever is available. So that might be porridge, that might be yogurt, which are foods that are obviously not appropriate for infants. And usually what happens is the baby will either develop diarrhea, malnutrition, both, and ultimately die. Thankfully, this family heard about our services. They live in our catchment area, and so we were able to enroll them, and we will be following this baby on a monthly basis for the next 2 years. Next slide, please. This picture is to give you an idea of what the environment looks like where we're working. So these are kind of typical homes where our nurses go out and visit guardians and mothers and infants. Next slide, please. This picture came from the first visit our team made to the home of that family. And I love this picture. I think it's very important for two reasons. One is that it really shows you the environment. Anybody who has had a baby that needed to take formula, whether your baby was completely 100% on formula or you're supplementing with formula, you understand what it takes to reconstitute the formula, to make sure bottles are cleaned, and how the feeds happen day and night. So in this environment, we have no running water, and we also have no electricity. So this is the challenge. Even when a family really wants this child to survive, this is what they're up against, in addition to the cost of procuring the formula. The other thing I love about this picture is the community here. So the woman in the blue is one of our nurses, but everyone else pictured here are either family members or community members. And I think this really speaks to the importance of this child within the community. So in Malawi, only about 60% of births are documented. Only 60% of infants receive birth certificates. So it is very common that a baby may be born and die without any official annotation of their life. But within the community, even though this child, we call this child a maternal orphan, this child is surrounded by people who really want to see her make it through childhood. Next slide, please. So this is the problem. We have these numbers for infant death, for under 5 death, but there are certain groups of babies who are much more likely to die than their peers. And we have found in our work that these babies are those whose mothers have died, whose mothers are very sick, or who are multiples, either twins or triplets. Next slide, please. So we don't have the data in Malawi how often this happens. This is not something that is being recorded or reported. We don't know officially what happens to babies after their mothers die, but we do know anecdotally by healthcare workers, community members, and we know from research in the region and in other low-income countries. So in 2019, there was a meta-analysis of 11 studies involving 11 cohorts from multiple countries within sub-Saharan Africa, Asia, and Haiti. And in that meta-analysis, they found there was a clear connection between child survival and maternal death. They also found that the risk correlated with the age of the child at the time of the maternal death. So I think when we put it like this, it just seems very, very simple, that if a baby loses a mother when still dependent on breast milk, automatically that baby is going to have a greater risk of dying. But this is not typically the way that we look at infant health. Next slide, please. All right, this is another picture from our program, and I think this picture illustrates kind of the scale of the problem. So when we're talking and thinking about, infants who survive their mother's death, that still is relatively a small number. Even if we're looking at the largest potential number of maternal deaths, and some of those mothers will not necessarily have survived. But this is a group of women that we are following, and we would say that every woman here lives within perhaps a 10-mile radius, and every woman here is caring for a motherless baby. So each of these infants have lost their mothers, and you can imagine the impact of a program that can help them through early infancy, as well as the impact of not having any support. Next slide, please. So the second group of high-risk infants that we include are multiples. We currently don't have the funds to follow all triplets in our catchment area, but we are following all triplets. And I love this picture. This woman is so beautiful. She actually came to our office today, and these babies are now 18 months. They are walking and, they are talking to each other. I mean, it's just really something incredible to watch and see. But in general, triplets also face a very high risk of dying in early infancy. So in 2017, there was analysis of demographic health surveys from 30 sub-Saharan African countries. And they found that twins account for an increasing share of under 5 deaths in sub-Saharan Africa. Currently, in 2017, that was 11% of all under 5 mortality. Excess twin mortality cannot be explained by common risk factors for under 5 mortality, including birth weight. So many times, the automatic assumption would be that these babies would be born premature, and then obviously they would have a greater mortality rate. But I think this, again, speaks to the idea that it is very difficult for a mother to produce sufficient breast milk to sustain 3 babies. So in the case of triplets, we encourage breastfeeding. We ensure that a woman has been tested for HIV, that she's adherent to her medications. If she is positive, her viral load is low, and then we support her to breastfeed and then also offer a supplement. Next slide, please. The final group of infants that we enroll are those with sick mothers. So this has been, there is less data on these babies, but there was a study in 2017 out of South Africa that looked at HIV positive women and correlated their health, their declining health and their deaths with the health of their children. So in this study, they found that the probability of a child death begins to rise 6 to 11 months prior to a mother's death. And again, they found that the children who were most likely to die were the youngest children. So, it's not that all of the women in our program are HIV positive, but I think the main take-home point here is that the mother doesn't have to die. Even if the mother is not as capable of being an advocate or of breastfeeding, her child automatically has an increased risk of dying within their first year of life. Next slide, please. Okay, so I created these pie charts to kind of give you a visual sense of the scale of this problem and also the potential for impact. So again, just a disclaimer, there is no specific data for Malawi. What I have done is I've used data from studies in the region, and then I've kind of put that together with census data from Malawi. So the numbers are not going to be precise, but I think generally the scale is the main message here. So the first pie chart on the left shows, if we're looking at all infants, all children aged 0 to 12 months in Malawi, those who we could categorize as high risk, so those being babies whose mothers have died, babies whose mothers are sick, and multiples, they would only constitute a very small sliver of total infants. I think it was around 3% is what I came to as an estimate. But if we look at total infant deaths, the percentage of deaths that those babies contribute to the whole is significant and is over 30%. Next slide, please. So our solution is family-based care. So this means that our nurses go out to the communities once a month to visit every enrolled baby, also every enrolled woman. They do health assessments where they're checking the weight. In the top picture on the left, our nurse is weighing a baby. They check vital signs. They ask guardians if they have any concerns or questions. They ask them about recent hospitalizations. They do a lot of health education, so they make sure that they are preparing the formula correctly, that they're using a clean water source. We do not use bottles. We only use cups because they're easier to clean in those settings. We also offer nutrition support. So for infants from 0 to 12 months, we give formula, and we start giving enriched porridge at 6 months and continue that to 2 years. We also speak to community members. So sometimes that means bringing people in to say, okay, this grandmother or this auntie needs help with this, and finding out who can be of assistance. Or also just general education of community members on related issues. Finally, we give every one of our beneficiaries a $5 equivalent for them to spend as they see fit. Generally, they are spending this on transportation, extra food, or medicine. I would say those are the most common things that they use the extra money for. Okay, next slide, please. Okay, in this bar graph here, I've separated out kind of the groups of high-risk babies and then compared that to our program. So the first bar is the mortality rate of infants who have lost their mothers. So this is very high, over 80%. The next is infants whose mothers are sick or unable to breastfeed, which is still over 20%. Next is multiples, which is around 15%. And then I've kind of created a composite just by the demographics or the categories of the babies that we enroll in our program. So the majority of the babies that we are enrolling currently are maternal orphans. And then we also, of course, the remainder is the infants of sick moms and the multiples. So our composite estimated baseline mortality would be above 20% in these infants. And that compares to the national infant mortality of 3%. So it's huge. So you just, again, see how much more likely these babies are of dying within that first year. And then the final bar is where our program sits. So we have been improving over the years. I would say our average for the last 5 years mortality is 4%. So it's still above baseline for the country. But right now we are, the past year, I think only 2%. We lost 2% of our babies, which is below the national standard. Next slide, please. So these are some of pictures of our nurses providing care, doing visits in the communities, and also pictures of some of their guardians, the babies that we've enrolled. Next slide, please. Okay, this final pie chart takes our impact and kind of puts it on that second pie chart, if you can bring that back to mind. So where we had, those high-risk babies were contributing over 30% of infant deaths. Well, if we are able to prevent the lion's share of high-risk infant deaths, the remaining infant deaths would be that little sliver of yellow. So this is potentially, would have a great impact on infant survival and even under 5 child survival as a whole. Next slide, please. The woman in the white on the left is one of our nurses and one of our babies. I have to say, I just really love to, one of the special things about our work is the bond that develops between our staff and the community, even the infants. It's really lovely to see. And sometimes we even have people who come with babies long after they've been discharged from our program. We have some that are now 11 years old that come by whenever they're passing near our office just to say hello. It's really lovely. Next slide, please. Okay, switching into maternal health in Malawi. I want to ask you to envision an iceberg. I think this is something that, you know, we've all used as an analogy in many different situations, and I think it applies also to maternal health. So if you think of that part of the iceberg that is above the water, that's visible, you know, that would be the maternal deaths. But the part that is unseen and is the larger part of the problem is maternal morbidities. So again, for those of you who are not familiar with these terms, maternal morbidities are, you know, severe illnesses that result as a consequence of something that happened either in pregnancy, delivery, the postpartum, or an exacerbation of a pre-existing health condition. So just as an example story, this young woman is someone who came through our program. She also attended all of her prenatal visits. She also went to the hospital as she was instructed to do to deliver. She ended up needing a cesarean section, and she had that done by clinicians in the hospital. Everything seemed to be okay with her health, I should say. Unfortunately, during the process of her labor and her delivery, her baby died. So she went home with a scar on her belly and no baby in her arms. And within about 2 weeks, she started noticing her abdomen swelling. And so she went back to the hospital. She was diagnosed with an infection. They opened her abdomen, irrigated her wound, closed it again, kept her there in observation, put her on antibiotics. The infection did not resolve. So again, she had another surgery to open. At that time, they noticed that her uterus was necrotic. So she needed an emergency hysterectomy in order to save her life. And then she remained in the hospital as that wound slowly healed over time. So her story is not evident in that piece of the visible iceberg. We don't see that when we talk about maternal mortality. You know, she would really be counted as a success. You know, she did everything that she was supposed to do, and she survived childbirth. The only tragedy, of course, that we would have here is that her baby has died. But anyone hearing the story obviously can sense the magnitude of the devastation she experienced and also the impact on the rest of her life. She's in her early 20s, and she has no living child and no possibility of having children in the future. So many women like her who have this experience also leave the hospital with severe depression. Next slide, please. So, you know, if we want to think about maternal morbidity, I guess the next question is, how do we really measure it? How do we think about it? And what do we do to address it? The problem is that, well, first of all, it's not this data is not being collected nationally. What we do have, again, are studies that have been done, and different studies have defined maternal morbidity slightly differently. So it's not always comparing apples to apples. So therefore, it's not easily quantified. But we do know that it is trending up. And there was a large survey that was done throughout sub-Saharan Africa, and in some regions, the percentage of severe maternal mortality was almost 20%. So almost 20% of all women who are delivering would experience severe maternal morbidity. And the reason this is so important that we should consider this issue is that there are significant impacts on maternal and infant survival. So as we already discussed, you know, if the mom is sick, if her breast milk dries up, she's not strong enough to care for her child, her baby automatically has a greater chance of dying. Even her young children have a greater chance of dying. She herself may have an increased risk of dying that lasts through the first year after that difficult birth. So typically, we're only measuring maternal, postpartum maternal mortality up to 6 weeks, and that's where we cut it off. If you die after that, we don't consider that maternal death. But in these cases, women who often are still in the hospital beyond that time frame, their risk of dying relating to those health issues that occurred during their delivery last way beyond those initial 6 weeks. As I mentioned, many of these women, and as you can imagine, have severe postpartum depression, and they also have problems with finances. So if you can think about, the setting that I've shown you, and now you have, one active member of the household who is hospitalized for extended period of time, no longer able to contribute to household work, but also drawing resources from that already resource poor environment. So oftentimes these prolonged hospitalizations sink families deeper into poverty. Next slide, please. In our context in Malawi and Lilongwe, the sepsis rate is 22%. That means severe infection of the women who are delivering. 22% of women who are delivering have a severe infection. And then we also know that not all the maternal deaths are being captured. We know this because when families come with orphaned infants for enrollment, and then we take those names and details and compare them with the official statistics, the person who records that, they don't always match. So we know that even the official easily enumerated figure for maternal health is not precise. For the women that we enroll, all of them have been hospitalized for over 3 weeks. 40% of them had hysterectomies in order to save their lives, and the average age of those women who had hysterectomies is 24. 40% of these women also lost their infants during either during the birth or shortly thereafter, and all of the women experience moderate to severe depression at discharge. Next slide, please. So the problem here is that the number of women experiencing prolonged periods of illness following difficult or near-miss deliveries, those are deliveries in which they almost lost their lives, eclipses the number of women who die during childbirth in Malawi. These women experience a prolonged impact on their physical, mental health, and on the health of their children. And for them, our solution is very similar to our solution for the infants. We find that family-based care for these women who have experienced near-miss deliveries improves their health-related quality of life. Next slide, please. So the way we know that we are having an impact on these women is that we use a tool called the EuroQual quality, health-related quality of life. It measures these 5 areas. A woman will rate herself on how she is doing in terms of her ability to carry out regular activities, her level of depression or anxiety, the pain she's experiencing, her ability to care for herself, and her mobility. So this graph shows you or gives you an idea of how women were at the point of enrollment. So that is the light orange here. Every woman that we enrolled ticked multiple indicators that they were not doing well. At the point of discharge from our program, which is a maximum, usually 4 visits up to 6 months postpartum, we only had 3 women who said that they were still experiencing some symptoms, but all the women reported improvement in all areas that they had initially stated they were having problems with. Next slide, please. So in conclusion, maternal and child health are inextricably linked beyond the neonatal period. So there's a lot of attention and focus from global health programs, NGOs, looking at preventative measures, primary prevention, which is very necessary. But we don't really consider what happens after a baby leaves the hospital. So we think about how a healthy mom and a healthy pregnancy can contribute to a normal delivery and a healthy newborn. But once the baby is born and is healthy, you know, it's up to the family to kind of do the rest. So we really need to look at, you know, how is the mother's health even beyond the postpartum period, even if it's not something that's directly related to her pregnancy or her postpartum. We have women who develop malaria, women who develop complications of HIV or cancer, other things that don't have anything to do with her pregnancy, but the impact on her child's health is the same. That baby automatically has an increased risk of dying. Second, the approach to addressing infant malnutrition in sub-Saharan Africa must expand beyond breastfeeding education. So I think for a lot of us in the West, when we think about, you know, women and infants in Africa, Latin America, we have this idealized image that these women are breastfeeding. They breastfeed early, they continue breastfeeding their children until they are, you know, 2 years old, they're walking around. And this is kind of the ideal that we hold up. It is true that breastfeeding is much more common. It starts early and it lasts longer in Malawi and throughout sub-Saharan Africa. And we want to do everything we can to definitely maintain that success. That breast milk is the ideal food for infants. There's no doubt about that. But at the same time, there are certain infants who either do not have access to breast milk at all, or women who are unable to provide the quantity that their infants need. There is no such thing as WIC in Malawi. And this is really an important need that must be met. So, you know, a lot of times I think in the interventions that that are created around malnutrition in infants is about how can we promote breastfeeding? How can we strengthen breastfeeding? How can we, you know, prevent the early introduction of foods? But I think we need to also look at what is going on with the mom. Health-related quality of life indicators enrich our understanding of maternal health in sub-Saharan Africa. So we need to move beyond, you know, looking at that tip of the iceberg, and we also need to move beyond kind of a linear model of thinking of a linear approach to maternal health. So it's not necessary that we first resolve the issue of maternal deaths before we then address other issues of health-related quality of life. We can find interventions that are appropriate for these settings to do simultaneously. Initiatives addressing maternal health in low-income countries should aim to reduce mortality and improve health-related quality of life. Next slide. These are a few quotes from some of our beneficiaries. I always, I should say, our team really strives to include their perspective in our work when we are creating our interventions and also when we're providing feedback to our donors. So I'm just going to read these here. When they came, they saw me and the baby both looking sickly and malnourished. Maybe it was demons. When they came, they helped the baby by giving us a flask, some milk. They also gave me a pack of soya flour, which they said I should make porridge. I started eating that porridge the same day. People then started saying I was looking better, that life was returning to me. I would say that they should keep doing what they are doing, and we would really be grateful if the program reached out to other areas because many children have passed away because they lack support. Because in an area that does not have the program, and once the mother passes away, the baby eventually passes away because they don't have support. I have seen a lot of change this far because this one fell sick sometime and was heading into being malnourished. I used the skills that I acquired from Chimwemwe Mbireki. I saw that the baby had started to gain weight and even started standing, and now the baby can walk. I have little stress now because this child is alive and growing. I never expected that this baby would be able to walk and meet the milestones like is happening now. All this has been possible because of the support that these people are providing to us. Next slide, please. So where do we go from here? Well, funding is always necessary to continue the work that we're doing now. We are the only organization in our district that is providing the support. There is one other small organization in the southern region that does similar work with infants, but they have a smaller capacity. Right now, we have 245 babies enrolled in our program, and we have 23 women. There are many peer organizations, other NGOs throughout Malawi who would be willing to adopt our model of care, but the problem is the cost of formula. No one wants to start babies on formula when they will not have the funding to sustain that formula throughout the baby's first years. Second is we need to continue with research. You know, as long as we are not capturing the data, these stories are not being told and will not be seen within the global picture of health. And then finally, we need help with advocacy. We need people who can understand these issues and bring them to the attention of organizations and actors that have the power and the funds to make a real difference in the lives of these babies and these women. So next slide, please. All right, that is my presentation. I'm really grateful for your participation and your attention. I'll hand it over to Dr. Patel.
Thank you so much, Joanne. We will now answer some questions from our audience that have been submitted during the presentation. Just a reminder to our audience, please be sure to type your questions into the chat box. And Joanne, I just wanted to thank you so much for sharing this. And my impression is that so much of what you've shared with us today is so relevant, both here in the US as well as all over the world. And so thank you for that. In particular, the issues you brought up about maternal mortality and severe maternal morbidity and the trends that we're seeing upwards, even in the face of challenges with measurement. So yeah, very relevant topic for all of us. So thank you so much. So while we're waiting for questions to roll in, we had a couple of things that we wanted to just talk with you about. So we know that increasing access to formula in the environment that you described carries some risks, such as increased risk of diarrhea and an overall decline in breastfeeding. So what do you do to minimize these risks?
Yes, I think this is really important to address. This is a concern, I think, of everybody who works in this space. Nobody wants to put at risk, breastfeeding as a whole. So what we do is, the formula is coming through our program. It's not like we would not want or recommend that we open up access to formula or reduce costs in general on the shelves in the stores of Malawi. We really want to be able to have close supervision over the reconstitution, the growth of these infants. And so I think this is one measure that we would put in place, just making sure that it's coming through us and that we have that good follow-up. WHO actually has a code for the marketing of breast milk substitutes where they kind of lay all of this out, that formula producers shouldn't be marketing in general, and that if their babies are out there who really need formula, that this should be provided by healthcare workers who are able to monitor and then also sustain, the formula through the needs, the time the baby needs the formula. Yeah.
Well, it looks like we have several questions coming in for you, and many of them I'm noticing a trend. So some are related. So, and you might have predicted this question, but can you talk a little bit about your funding? Are you funded at all by USAID? And are the current events surrounding US foreign aid going to impact your work, if at all, or how?
I really appreciate this question. It is an incredibly stressful time. I think for those of you who have asked this question, you are feeling it on the other side. We do not receive any funding from USAID. We don't have, our larger donors are actually from Australia, we have from the UK, and then we have a lot of individual donors from the States. It does change the landscape in general here, and we are seeing the impact. I mean, one of the main ways that it's affecting our clients is that this USAID funding supported the HIV clinic that supervises and manages most of the patients in the country who are positive, checking their viral load, making sure they are adhering to their medications, and that has essentially shut down. So the government is trying to keep that going, but that also means for us, that the women that we have in our program who are positive and who are breastfeeding, it's going to be a lot more difficult for us to monitor them. We're going to start really worrying about them transmitting HIV to their babies. Another way it's impacting us is just we are seeing that people who are working in our space are losing their contracts, people are losing their jobs. So it's definitely being felt here. But as our organization goes, we are not feeling that impact directly at this point.
Okay, again, several more questions coming in. So one question, how often is mastitis encountered with breastfeeding moms?
So here we don't even really see the mastitis until it gets to the point where it becomes an abscess. I think a lot of times, just the level of care that's available is so minimal that it's really only the highest acuity cases that are being treated. So we do have women who come to us with incredibly horrible looking sores all over their breasts and are just not able to breastfeed anymore. And then of course we enroll their babies. But in terms of, mastitis occurring out in the community, I honestly, I don't have any idea, but it's there for sure. It's there.
Thank you. A comment and a question from our audience. It sounds like the formal health system is also failing these mothers with high risk of sepsis and postpartum health. How does your work also end up encouraging families to still have faith in the health system instead of looking at alternatives?
Well, I would say, the alternatives are minimal at the moment. Maybe in years past, women would go to a traditional birth attendant and deliver outside facilities, but now it has been penalized to the extent where community members will report if a woman is delivering at home and report on the traditional birth attendant, and they will be fined. So there really is not another option for women. I think, there are many other NGOs and international organizations that are working within the healthcare system. You are absolutely right that it is failing. I mean, a sepsis rate of 22% is astounding, to say the least. So there are organizations that are working on training, that are working on infection prevention, but this is just where we are. I think what we are doing at this point is really kind of providing the net and after the crisis. So we are really doing the tertiary prevention.
Great, thank you. One member of our audience asked if you could repeat the name of the screening tool that you use to measure mothers' quality of life at time of enrollment into the program and at the end of
It's Sure, it's Euroqual, EUROLQOL. Euroqual, it's health-related quality of life, and I think they have two different tools. One is a 3-point scale and one is a 5-point scale. So that is what we use, and it has been validated in Malawi, translated into the local language, Chichewa. So that's what we use.
Thank you. One member wants to know, are there NGOs working in Malawi to bring clean water solutions to rural areas? And there are a couple of these types of organizations that are well connected or based in Austin. So this is one of our Austin audience members.
Okay, great. Yes, there are. There's definitely a lot of organizations that drill boreholes. It is, how can I say? It remains a problem. I think one of the issues is sometimes even when a borehole is present in a community, if there is a problem with it, people might not have the skills to fix it. That's a whole nother skill set that has to happen. But there often are boreholes within walking distance from most communities. But it still is a difference of, having water piped into your house where you can wash and sterilize and have it, or you have to walk somewhere and carry it back on a bucket on your head, in order to prepare formula for a baby.
We have a question about how did the district get chosen to host this program?
Really just the population size. So the scale, we wanted to be in a place where we could have the most impact. So Lilongwe is a larger city. I mean, it's probably the same size as Austin in terms of population, around that size, but it doesn't look anything like Austin at all. It looks like a very small town, because still even many people who live in the city don't have electricity. Um, and then the district. So we have Lilongwe City is centered in Lilongwe District, and it is also, has the greatest population in the country. So this is where we wanted to start, and we are hoping to expand. We actually have a memorandum of understanding with 2 other peer organizations that work in different districts that we are trying to add on our model of care to services that they are already providing. So one of those organizations provides maternal and child health care, direct services, but they didn't have anything for these high-risk babies or postpartum women. And then the other organization is focused on orphans. And they do a lot of support from, very young all the way up to, early adulthood. But again, they didn't have the means to add on this piece for infants. So we're doing that with them. And we hope to be able to continue kind of to expand our services through peer organizations in the country.
Okay, we have another question about what is your approach to the interpregnancy interval period for women that you're working with who might be considering future pregnancy?
So as part of our health education, we do discuss family planning. That is something that we do not provide as an organization, but it is available within the district. So women who are interested in family planning, they do have access to those services here. That is not always the case throughout the country. And then, of course, if a woman is breastfeeding, that is also a way to space children at least 2 years, but it is a topic that the nurses discuss with women. I will say, for the majority of women who we are caring for, many of them no longer have a uterus, so there isn't really an issue of fertility. And then of the babies that we are caring for, the majority of them also are maternal orphans. So they are being cared for most of the time by grandmothers who are often postmenopausal. So also not often an issue for our clients.
One of our audience members wants to know, have you found the use of group prenatal care or postpartum care useful in addressing maternal and infant health issues? And if so, what are some of the challenges in implementing a group care model in Malawi?
I wish you could just see the prenatal clinic in Malawi. It is so different than anything that you can imagine in the States. So they do not have group prenatal care in the sense that we practice it in the US. I love the model. It is wonderful, but they will care for, I mean, many times it's literally 100 or over 100 women in a matter of a couple hours. So the way the women move through the clinic during prenatal care, it's really, they've kind of given a talk. Everybody's told, you're at this stage of pregnancy. These are the issues that need addressing. Maybe it's you need to take your iron tablets, or you need to sleep under insecticide treated bed nets. And then those women get their bellies checked really quick. So they are kind of present for each other's checks, but there's not an opportunity to really have discussions and engage them in their care. And similarly, in postpartum, most of the time, if it's a normal delivery, I mean, women are really, they go home within 24-hour period. They don't stay at the hospital for extended period of time. And many times, transportation is an issue. Women are coming perhaps from long distances, and even those who come within town, the cost of the transportation would be an impediment to having them come back for more frequent visits or group care. But it is a wonderful model, and not saying it's impossible, but it would be very challenging to implement in this setting.
One of our audience members would like to know, they would like to find out whether the organization has ever considered expanding the program to other countries in Africa.
Not at this time. I think really because we are just serving such a small portion of Malawi. I mean, it's really only 5% of the population would have access to our services at this time. And I think we first need to trial out how expansion looks within Malawi, but it definitely is a need within the region. And, you know, if there are other organizations that are willing to take on the model, we would be happy, you know, to mentor or to talk, you know, to form a partnership with somebody else. But I think it wouldn't be, we're not in a position where we could be the direct providers of care or, you know, expanding at that level into another country. Yeah, it is an issue, I will say. I think that these issues, you know, are not limited to Malawi. They would be definitely within sub-Saharan Africa and probably within all low-income countries.
Have you thought about shifting the paradigm to look at pregnancy as the window of opportunity for intervention, or perhaps adding this as a mechanism of intervention?
So there are many NGOs and organizations that work during pregnancy, you know, to really prevent poor outcomes. And we do, you know, we do participate in subcommittees from the Ministry of Health in our districts, and we do interact with other organizations. We are actually based on the grounds of the district hospital in Lilongwe, but because there are many other organizations that are already operating in that space, and there are no other organizations kind of working in the aftermath space, that's why we've chosen kind of to remain in this area and for that to be our kind of our niche. Because I think if we divert our resources, that means that there will be more babies who wouldn't be able to receive the services, and there's not an alternative at this point for those infants.
And it looks like we're getting close to time, but we do have one last question. So how do you spread the word about the program to mothers and families?
Right now, we work with healthcare facilities. So our nurses, when they're going around throughout the district, they stop in at hospitals, healthcare facilities, they educate the staff there about what our program does. And a lot of times, you know, if a family is looking for support, that's where they're going to go. They go back to the health center. So we want to make sure that the staff, not only who are in the prenatal clinics, but even in the medical wards, because sometimes we have women who are admitted, like I said, for an issue that has nothing to do with pregnancy. Nobody knows that she has a nursing baby. So we want those staff to know. We even reach out to the staff of the mortuaries. So if there's families that come with an infant, that they know where they can refer those families. We also, you know, at this point, we've been working in this district since 2008. So a lot of people know about our work just through community. There are people who say that, you know, someone saw me and then escorted them to the office. It was a former client who escorted people. So most of our referrals come from healthcare workers, but then a lot also come from community members. And then we're obviously also speaking to other peer organizations, Ministry of Health, who help us to spread the word in Malawi.
Great. Well, thank you again, Joanne, for all the incredible work that you're doing, addressing a very much needed global health issue. We really appreciate your time and your willingness to share with all of us. We look forward to keeping in touch with you and learning more as your program continues. And so that, I think, is the end of our questions. So really appreciate it again. Next slide, please. And so thank you everyone for attending today's webinar. The recording of the webinar, the slides and resources mentioned will be posted on msdcenter.org, along with information about the upcoming webinar that we have, Health Promotion for Children in Rural Settings. So we're excited about that. Hope that you can attend. And you'll also receive a follow-up email with links to all of these items. Thanks again for joining us today, and we will see you again next time. And thanks again, Joanne.
Thank you.